Welcome, everyone. This is session 341, Ask a Doctor Your Questions about papillary and follicular thyroid cancer and creating clarity before you go home. So I think this is a great session for all of us. So Dr. Sherman is an endocrinologist and chair of the Department of Endocrine Neoplasia and Hormonal Disorders at the University of Texas MD Anderson Cancer Center in Houston, where he is also a professor. A magna cum laude graduate of Harvard College, he received his MD from Johns Hopkins School of Medicine, followed by internship, residency, and fellowship at Johns Hopkins Hospital in Baltimore, Maryland. His clinical practice is focused on delivery of research-driven care for patients with differentiated and medullary thyroid carcinomas, along with thyroid complications of cancer therapy. His research interests for the past 25 years have centered on novel therapies and monitoring techniques for thyroid carcinoma. He has been a member of thyroid cancer guidelines panels for both the American Thyroid Association and National Comprehensive Cancer Network. And he was a founding member and former chair of the International Thyroid Oncology Group. Dr. Sherman is also a ThyCa medical advisor. So with that, I welcome you, Dr. Sherman.
Well, thank you very much. It's a real pleasure to be here. And first, I'd like everybody to stand up in the room and give yourself a round of applause for coming to this meeting, for coming to this conference, and for making it through to the last day. So congratulations. For those of you who don't know me, you just heard kind of a brief summary. I am an endocrinologist, and I've spent the last 40 years as a thyroid physician. I've had the good fortune along the way to be at the MD Anderson Cancer Center for most of those 40 years. And as you heard, my clinical practice, my research, my academic work has all focused on primarily thyroid cancer. I've also had the privilege of being the father of a thyroid cancer survivor. My youngest came home one day from her gynecologist saying, my doctor said I have a lump in my thyroid, I should talk to my dad. And I said, no, you need a doctor. I'm your dad. But we went through the journey of her evaluation and multiple biopsies and surgery and radioactive iodine and the struggles she's had with thyroid hormone therapy over the years. So I've had a little bit of an insight on kind of both sides of the examining table. I also have the perspective of having been doing this for 40 years, meaning that I have watched the pendulum swing back and forth with some of our standards of care, coming up in an era where there was a strong argument about how much surgery do you do, and then there was total consensus that you completely take out the thyroid in everybody. And then there was consensus going in the opposite direction and a movement towards less surgery. I grew up in an era where anybody who was diagnosed with papillary thyroid cancer not only had a total thyroidectomy, but radioactive iodine treatment and lifelong high-dose thyroid hormone therapy, until we began to accumulate evidence to say that, well, that really wasn't necessary for many people, maybe even most people. Watched the era develop of the suggestion that some people didn't need any surgery or any treatment whatsoever, the concept of active surveillance. Also came up in an era where if you had metastatic thyroid cancer, papillary or follicular, there was one treatment. You got radioactive iodine therapy to treat the metastatic disease. And if that didn't work, you just got it again and got more. And we kept treating and retreating because, you know, as I was mentioning to somebody earlier this afternoon, you know, it was the only tool we had. And so if the only tool is a hammer, everything looks like a nail. I grew up in an era where the concept of clinical trials and experimental therapies for patients with advanced thyroid cancer didn't exist. Banging our head against the wall, trying to get pharmaceutical companies involved and interested, and watched over the decades as our understanding of the biology of thyroid cancer and the inherent similarities between thyroid cancers and other types of cancers gave us the opportunity to identify novel therapies that could be specifically beneficial in thyroid cancer patients, or, and much to the pleasure of the pharmaceutical industry, applicable to other, even more common cancers as well. So I've seen a lot of change over that time, and now am pleased to participate in a field where we have broad menus of options for many people at each stage along the way, even at what kind of testing we do for diagnosis, what kinds of initial treatment, what kinds of follow-up do they get if they have metastatic disease outside the neck, what sorts of therapies are available, needed, or could be deferred. So it's become actually very gratifying to work in this field, and I thank all of you for being patients and participating in your care. And for those of you who have been in clinical trials, a special thank you to any of you, as it takes a real special person to volunteer to be in such studies. So with that, Gary Bloom asked me to answer questions and to try to, what did he say, to bring clarity at the end of the meeting for those uncertainties that you have, the things that you're not sure about or wanted to hear, reinforced. I can assure you, I didn't attend the sessions that you attended. So I may not know the different things that you've heard. So I may not necessarily agree with what you've heard already. I hope that doesn't provide more confusion than clarity. But a great deal of what we do in this field is a gray zone. And we deal with a bit of uncertainty from time to time. So with that, I'd like to open it up, and I'll do my best to bring clarity.
Okay, so first we'll start with some in-person, and I'll bring the mic over to you so our virtual attendees can hear. So any in-person questions?
And I'm going to apologize to the people at home, but I'm going to walk over to our questioner so that I can see her as well as hear her.
So I'm undiagnosed. I'm going to surgery, and the question is, because there is a difference in opinion of what kind of surgery I should have. I have Hurdo cells that were found on both sides, level 3, level 4. Molecular did not necessarily show much, at least on one side. Vast majority of disease is on one side, 2 tumors in isthmus, less so on the right side, but nevertheless one nodule that already shows some kind of Hurdo cells on the right side. Is starting with lobectomy a good idea, given the fact that I do know I have nodules on both sides? Now the nodules on the side I will be leaving are 1 centimeter or less. There is one cyst that it's 1.5.
So if I understand correctly, what you're telling me is that you have a multinodular thyroid gland, multinodular goiter. You've had biopsies that show or suggest Hurdo cell tumors. Whether they're cancers or not is uncertain.
Correct.
Which is usually the case with this type of nodule, that biopsies would not be able to show the presence or absence of cancer specifically. But it sounds like molecular tests have suggested that maybe there was high risk for it.
Actually, I have one more thing to add. I know it's not going to probably help in this case. I do have a PET CT uptake in one of the nodules as well. It's a focal uptake.
Doesn't change too much with that, but okay. So lumps on both sides of the thyroid, high risk for being cancer. On one side, they're less than 1 centimeter. The other side, there's at least something that's bigger than that. And the question is, what would be the optimal surgical approach? So we can be definitive in saying we don't know, and there isn't a single right answer here. It is a matter of preference. So first of all, for those who are unfamiliar with Hürthle cells, which are now called oncocytic carcinomas or oncocytic tumors, but these are cells that derive from within the thyroid gland. They create tumors that have often a very different mutation profile from papillary or follicular cancers. They may really be a unique tumor unto themselves. You can see Hürthle cells in a variety of benign conditions. Just inflammation within the thyroid alone can generate Hürthle cells. You can have benign Hürthle cell tumors, and you can have cancerous or malignant Hürthle cell tumors. When they're malignant, they tend to be a bit larger than the average thyroid cancer. They sometimes spread to lymph nodes in the neck, but they have a slightly higher frequency of spreading to other parts of the body. And they typically do not, although never say never, but they typically do not respond to radioactive iodine treatment. So the initial question comes down to a choice between do you take out half the thyroid with the larger lumps, or do you take out both sides and do a total thyroidectomy? The advantage of the total thyroidectomy is that you'll have greater certainty at the end of the day as to whether you had cancer or not, because you could have benign Hürthle cell lumps on one side and cancerous on the other. So that would be one possibility, give you peace of mind from that. If your doctors felt that radioactive iodine treatment would be needed after surgery, if there was cancer, then you'd need to have the whole thyroid taken out. Although I think most of us are reluctant to give radioactive iodine in the setting of Hürthle cell, because again, it usually doesn't help that much. And then there's the risk side, which is that, with surgery, you run the risk of injury to the blood supply for parathyroid glands that control calcium and the nerves that control the vocal cords. And so the answer may come down in part to how good are the surgeons that you have access to. Because if you have superb surgeons where the risk of those complications is very low, maybe 1% as a permanent risk for each of those, then that might be a very different equation for you than if you had a 10 to 20% risk of that kind of complication. And so a very important question is to directly ask a given surgeon that you're interviewing, that you're deciding what to do with, is what are their complication rates? Not what's a national average, but what's theirs. And also to ask them, and how many thyroid cancer operations do you do a year? Because unfortunately, there's a very clear and well-documented relationship between the amount of operations that a surgeon performs for thyroid cancer and the complication rate that they experience. And ideally, you want a surgeon who does at least 50 a year. And you probably want to avoid somebody, I hope there are no surgeons in the room, but you probably want to avoid somebody who does fewer than 5. And 5 is about the average nationwide. So, you need to inquire carefully. So I think that, at the end of the day, this is where I would invoke what I call the sleep test, which is which approach is going to help you sleep better at night. The total thyroidectomy to give you greater certainty, or just starting with where the nodules are over a centimeter, and on that side where they're larger. There is not really a wrong way to proceed. If you do have cancer and on the other side, those nodules grow over time, you can always go back and take out the other side at a later time, and probably with no greater risk and with no greater complication. So If you want absolute certainty, then you're only going to get that from taking out the whole thyroid.
Thank you. Okay, we'll take another one in person and then I'll go to a few online.
With the anticipated changes for the guidelines next year, they talked about further classifying the intermediate risk patients. How do you anticipate that impacting recommendations for long-term care and follow-up?
So the question is about something that hasn't happened yet, which is release of the latest version of the American Thyroid Association guidelines. And so because I have not had the opportunity to actually read what they're proposing, I'm going to politely decline to answer.
That's fair.
So, although this is very relevant to me because in about 4 weeks at the American Thyroid Association annual meeting, I'm going to be on a panel that's supposed to be talking about, treatment for patients with quote, the new intermediate risk for recurrence from the ATA guidelines. And I'm not exactly sure what I'm going to be able to say unless somebody gives me an early copy.
Okay, a virtual monitoring oncocytic metastatic to lung, finding PET without thyrogen okay, level of finding administered important.
So back to oncocytic or what we used to call Hürthle cell. So one of the characteristics of oncocytic tumors and the reason why they're called oncocytic has to do with the very characteristic way they stain pink with a certain evaluation by pathology. And the reason that they stain pink is that they're full of these little structures called mitochondria. These are the energy engines of the cell. And there is, and the main source, or one of the main sources of energy that they use, is these cells suck up sugar or glucose out of the bloodstream, and they use it to power the growth and the metabolism of that cancer cell. Now, let me just step back for a second. Do not take that to mean that eating sugar feeds the tumor, because your body is going to generate all the sugar that tumor needs, regardless of what you take in. So that's not my take-home message. But there is this scan called a PET scan. And one of the things you can do with this technology is you can take a radioactive form of sugar, inject it into somebody, and scan to see where it's being concentrated, where it's being sucked up. It'll show you lots of things. It'll reassure you that your brain is good, because the brain lights up like crazy on a PET scan because it uses sugar, and your heart. So that's all good. It'll show you areas of inflammation where sugar is powering the inflammatory response to injury or infection. And it will show you different kinds of tumors. And there are some tumors that are classically very active on PET scans, like lymphomas or lung cancers. Thyroid cancer is an interesting story because most thyroid cancers do not use much sugar. They're very quiet, metabolically quiet tumors and don't suck up much sugar at all. And in fact, you can have papillary thyroid cancer or follicular cancers that you can't see at all on a PET scan because they're metabolically so silent. Oncocytic tumors or Hürthle cell tumors have a very high rate, though, of being positive on PET scans. And it can be a very useful technique for long-term monitoring, maybe not as part of the initial evaluation, but long-term monitoring for a patient who has spread or metastasis of oncocytic carcinoma. When you do a PET scan, it's usually coupled to another machine, to a CAT scan. So with the PET scan, you're kind of recording and measuring metabolic activity, something functional And with the CAT scan, you're recording structure, and then a brilliant computer kind of merges these two pieces of information together and gives you information about size and metabolic activity of specific structures. So you can follow these tumors on a PET CT, and you can follow the metabolic activity, which would get reported as something called SUVs, and you can follow the size and the shape and the distribution of nodules. So it is a very good way to follow those kinds of patients. It doesn't tell you how to treat or when to treat a patient with therapy, chemotherapy or targeted therapies. But it can be a very key technique along with thyroglobulin monitoring to determine the overall rate of change and progression and distribution of Hürthle cell. So it's a very excellent scanning technique.
Okay, thank you. Another question. How can I affect my metabolism through diet and exercise post-complete thyroidectomy and RAI? I had papillary thyroid cancer.
Can you start that one again?
Sure. Can I affect my metabolism through diet and exercise post-complete thyroidectomy and RAI? I had papillary thyroid cancer.
So when somebody has had their thyroid taken out, regardless of whether they get radioactive iodine after that or not, they are hypothyroid, meaning they don't make enough thyroid hormone and require supplementation. Normally, the thyroid gland makes two different types of thyroid hormone in a very carefully prescribed fashion and ratio. So there's T4 and T3 are the two types. The normal human makes about 15 times more T4 than they do T3. And it makes them in sort of a continuous release. They're constantly being produced, and there's very little to no diurnal variation or change from hour to hour over the 24-hour cycle in these hormone levels. When you take, as most people do, just levothyroxine, you're taking just T4 alone. And for most people, let's say about 85%, that works pretty well. But there's about 15% of people who don't quite feel back to normal, or what they remember or perceive as how they felt before they became hypothyroid. And that not only applies to if you become hypothyroid because your thyroid's taken out, but it also is seen in people who become hypothyroid because of the more typical causes of inflammation and what's called thyroiditis. So there's been some effort at trying to see, are there other ways of treating with thyroid hormone using combinations of T4 and T3? But frankly, it's very difficult with our current available medications to really replicate the way the human thyroid produces the hormone and releases it. And there are still folks, no matter how much we can fine-tune their medications and how good their blood tests look, who just don't feel back to normal. And one of the major issues or concerns can relate to weight management. So, there are efforts to look at exercise regimens and diet manipulation. To be honest, I think that the answer to your question is we don't really have a great answer, unfortunately, because there's still this core of folks who don't get back to where they were beforehand. And whether it's their thyroid hormone mix, whether there's something else that the thyroid makes that we can't account for, whether there are some differences or sensitivities to the ratio of T4 to T3 that somebody's taking in. There are some genetic variations in the enzymes that convert T4 to T3 in the body. And so that has some correlation with how people feel. But we've yet to figure out really a great answer for how to make it better. I do think it's important, though, to focus whether you're hypothyroid or not, to focus on exercise, to focus on food intake and healthy diets, watching weight as best one can. Always easier to say than to do, however.
Thank you. Okay, any in-person questions? I think, did you have your hand up earlier? Are you, okay. Anyone else? I'll come back to you. Okay. I'll come around this way.
Sort of in line with how, we try to replicate the missing thyroid hormones, but people don't ever really feel back to normal. I was wondering if there was any conversation in regard to the thyroid's potential involvement in the endocannabinoid system in the body, and how that might not really be addressed, or we don't really know its role, if at all. And if there's any conversation about exploring that to eventually help patients feel more normal.
I mean, there's all sorts of conversations that go on about this conundrum. We know that the thyroid produces more than just T4 and T3. And also there are a variety of precursors and metabolites of T4 and T3 that the thyroid produces and releases. We know the thyroid normally makes calcitonin to a degree, and a hormone that in other animals helps to regulate calcium levels. But at this point, we don't really know of a function that it has in humans. It's sort of vestigial, we think, but maybe there's something, about calcitonin or other products from the C cell. So I think there's a lot of conversations and a lot of research that has yet to make it to prime time to answer the question.
Good afternoon, Dr. Sherman. I know this is supposed to be for patients, but I hope it's okay if I ask a
Are you a
question.
plant? So Christina Bowie is one of the advanced practice providers at our institution, specializing in taking care of patients with very advanced thyroid cancers.
Yes,
Yeah.
but I still have so much to learn, and I really appreciate the opportunity to learn from you. So the patient who asked the question about, or the participant earlier who asked the question about the PET scan, I thought they said something about a thyrogen stimulated PET scan, which is not
Thank
something
you
we
for
do.
reminding me.
Yeah, this is
Yes.
not something we do at MD Anderson. So
Yes.
I wanted to ask, what is the rationale for the providers outside of MD Anderson who do thyrogen stimulated PET scans?
So thank you for bringing that back. This is something that actually has been studied very carefully. So the thought was, when you have a radioactive iodine scan, right, you need TSH, thyroid stimulating hormone, to stimulate the thyroid cells to suck up the iodine. And whether you get that endogenously because you make somebody hypothyroid and let their TSH levels rise without hormone for a few weeks, or you give them the synthetic recombinant TSH known by the brand name Thyrogen, but you have to do something to raise TSH. So early on, when recombinant TSH came out and the clinical trial showed that it was effective for radioiodine scanning, a group of physicians said, well, is it important for PET scanning? Does it also stimulate glucose uptake or sugar uptake? And there were some anecdotal experiences that suggested that, in fact, it made a difference. So we, along with folks at Johns Hopkins and Institut Gustave Roussy in Paris, did a clinical trial where we looked at patients who had PET scans with and without recombinant TSH as a preparation. So did they need a high TSH or not? And really the bottom line was there was no clear benefit to giving them the recombinant TSH injections. You might have seen a little bit more, but it really was not clinically significant. And therefore, it's been our clinical practice for the last 20 years since that study was done to generally not do it with TSH stimulation.
Hi, Dr.
For
Sherman.
once, there I can tell you there is an answer because there has been a study.
Dr. Sherman, I'm Mr. Lee, and I appreciated the great opportunity to directly ask a question from you. Yeah, well, my situation is that 22 years ago, I had a total thyroidectomy and followed by radioactive iodine treatment. And then it was quite for about 16 years, and at the MD Anderson Survival Center. And one time I identified one lymph node in the neck, and then later on removed by Dr. Clayman. It was very successful. After that, the second surgery, it was quiet for 2 years. Both TG and the TG antibody are all negative. And then after that, and then TG level is greatly, slowly increases, though the TG antibody is still negative, always negative. So now currently for about 1 year, the TG level stays on the range of 5 to 6. So now the doctors, have different opinion. One provider said that we should take the wait and see approach, but the other provider said, no, you have the certainly measurable disease over there. No matter provider also did the whole body PET scan and the bone scan, and the neck area ultrasounds are very clean. So that first doctor said, wait and see. The second doctor said, no, we needed to take some actions, something like the radioactive iodine or something redifferentiated. But first doctor still did not agree. So, I got puzzled. What is your view about my case?
So this is, if I've followed correctly, this is the issue of a patient who has a persistently detectable tumor marker, the thyroglobulin level, that clearly indicates that there is cancer remaining. There's virtually no other possible explanation for the blood test result. But the tests that have been done to try to find where the cancer is, to find the source of the thyroglobulin and to treat it, or to show what could be done for treatment, have been negative. And so do you, in essence, say we're going to do something because we know something's there, or are we going to do something because we know what we're doing? And in a sense, the way I'd look at it is, are we treating a patient and their tumors, or are we treating a blood test result? There is no evidence that doing something to you simply because your thyroglobulin is positive, there's no evidence that it's going to help you live a day longer than doing nothing at all. Second is, you're not doing nothing. You're on, I assume, high-dose thyroid hormone treatment to suppress your TSH. And actually, there is evidence that that by itself is beneficial in slowing down tumor growth and in helping people live longer. So it's a question of high-dose thyroid hormone versus high-dose thyroid hormone and some undirected diffuse treatment because there's cancer someplace. And I tend to fall on the side of the more conservative approach in situations like this. If your thyroglobulin were doing, 2, 10, 50, 400, I might be looking a little bit more aggressively and frequently for where the tumor is. But if you're hanging out at around 4 or 5 and it's sort of plateaued for a while and it's stable and they've done, all of the key things that can be done to try to find it, it could take 2 years, it could take 22 years before it finally shows up. And my bias tends to be, if it's too small to see, then it's too small for me to effectively do something. Now, if you say, again, I can't sleep at night, I got to do something, There's little evidence that radioactive iodine by itself would be beneficial. It might lower the thyroglobulin a little bit, but it rarely will make it undetectable. So I'm not sure what gets gained with that. And I don't think that anybody would advocate using chemotherapy or any of the newer molecularly targeted therapies in a situation like this where the only evidence of the disease is the blood test. Do you have anything to lose by doing a diagnostic radioactive iodine scan and seeing if that helps locate the tumor and helps you find something that's treatable? I don't think that that's wrong. Although I think for many reasons, the likelihood it'll be positive is low, but it's not unreasonable to think about that. But I would not give radioactive iodine simply because the thyroglobulin's high. I would give it because you have something that clearly would benefit from treatment that you can locate and follow. Sort of, I hope that helps there. Use the microphone, please.
Thank you. Thank you. My question was that is that possible the PET-CT scan will get the negative or false negative result?
So there are several reasons for PET scan to be negative. A false negative depends upon what you're looking for. And as I mentioned before, papillary cancers are notorious for being negative on a PET scan, particularly if they are not growing.
Ah,
And so small, stable papillary carcinomas will classically be negative on a PET scan. And so to me, that's a good thing. And the evidence was that, positive PET scans are predictive of growing tumors. Negative PET scans are predictive of stable tumors. The other possibility is it could simply be too small, that the PET scan cannot see things that are well below a centimeter in size. And so it can be negative. I'm not sure I want to use the phrase false negative. It can be negative simply for technical reasons that, will require the tumor to eventually grow. But if it's that small, we have no evidence that doing something to you for it is beneficial.
that makes sense. I certainly believe that, and I will have better sleep tonight. Thank you.
Good. I'm glad.
Okay, we'll have one more in person and then I'll switch back to virtual.
So I'm going back to the oncocytic and I'm gonna ask a question about PET-CT. And I know with oncocytic it's not so easy, but if the max SUV, so the measurement of sugar, it's somewhere in between, so like 5 or 6. Does that have any correlation pointing more towards adenoma versus carcinoma, or is there no correlation?
So an SUV of 5 to 6 is only mildly positive, and is not, I think, very informative in this question of what.
So it
breast
doesn't
cancer
point,
does.
yeah.
Not
And
with that kind of, if you told me it was 40 or 50, that would be different, but 4 to 5, I don't think you can call that.
And if there is secondary site showing, even though that site seems to be negative, but the max SUV in the bone is very similar to what the one was focal in thyroid.
So if there was a positive site outside the thyroid, then I would be wanting to know what that is. Is there a structural correlate on CAT scan? Because sometimes you can see areas of mild SUV uptake that don't seem to correspond to any lesion itself. And we may look very carefully with, with x-rays and with CAT scan at the bone in that situation, but I would be suspicious because that is one of the places that kind of tumor can spread to. But again, false positive does occur in those situations. And I think you'd really want to not be making decisions just simply because there's some vague positivity on the PET.
Thank you.
Okay, let's see. I was diagnosed with papillary thyroid cancer in January, had a total thyroidectomy in March of this year. 22 of 70 removed lymph nodes were cancerous. I had RAI in July. I would like to know when my thyroglobulin level will be indicative of my current cancer level. It came back at 9 months after surgery, and that has had me worried.
So I assume that means the thyroglobulin is detectable. So thyroglobulin is a very useful marker of the presence or absence of thyroid tissue, both benign and malignant. It can kind of, after thyroidectomy, thyroglobulin levels kind of tend to reach their bottom or their nadir at least 6 weeks after surgery. After radioactive iodine treatment, especially if there is a significant amount of normal thyroid tissue or thyroid cancer tissue that was treated by the radioactive iodine, it may take a long while for that thyroglobulin to really bottom out or potentially go away. And I say that I've had patients, for example, who have had metastatic thyroid cancer to the lungs, and they got treated once with radioactive iodine, and their thyroglobulin was still positive a year later. But as you follow them over time after that one treatment, the thyroglobulin continued to decline, and it may have taken 5 years for the thyroglobulin to completely go away. So a single point in time, a single measurement doesn't necessarily tell you what's going to happen, but following it sequentially with multiple measurements over a year or two would give you much more information about whether this represents tumor that is persisting or growing, or is this tumor or normal thyroid tissue that's just taking its time dying off.
Okay, thank you. And this next person, somewhat similar, but they had their total thyroidectomy and RAI treatment last in June of 2023, but then their thyroglobulin has increased from 2.07 in March of 2024 to 2.63 in July. And they're advised by endocrinologists to visit oncologists for a possible recurrence. So I guess they're asking for recommendation. And the same person saying, I would like to know what changes in my body I can feel to know if the TG is increasing and how I can prepare myself for a better future. Does it have a connection with ANA and ESR?
Okay, so let me kind of parse that out. So thyroglobulin went from about 2 to 2.1 to about 2.6 on repeat measurements in less than a year. There can be a few factors that contribute to that. You'd want to look at what the TSH level was concurrently with each of those, but I would say it's a pretty small change. And I'm not sure that you'll necessarily define somebody or find a high likelihood of recurrence simply because their thyroglobulin has changed a little bit like that. That's well within the variation that you can see from measurement to measurement. On the other hand, if it continues to trend upward, there's probably a better possibility of tumor that's growing back. Given the initial description of the extent of tumor, I would think the most likely place would be in additional lymph nodes in the neck. Since you had more than 20 that were positive the first time around, you're at high risk for recurrence. But if that thyroglobulin were trending up, we would probably look at you with not only ultrasound, but CAT scan of the neck and of the chest, because the next most likely place that disease could be hiding would be either lymph nodes in the upper chest or mediastinum, or in nodules in the lungs. So if I see somebody with a thyroglobulin that bottomed out and is now rising steadily over time, I go looking for the most likely and then the next most likely place it could be. I think the question of who you see and what is done may depend upon what resources you have available to you. So in many places, an oncologist wouldn't necessarily be the next stop, because in general, most oncologists deal with chemotherapy or no chemotherapy. But if your endocrinologist feels that they need, guidance, then an oncologist could be, your local oncologist could be the best option. But doesn't sound necessarily like this automatically needs to be thinking about chemotherapy. I think the odds are highest that this would be something that may need additional surgery in the neck at some time in the future. In terms of, does the elevated thyroglobulin relate to other blood tests like ESR or ANA? ESR is a very nonspecific blood test that reports out on levels of inflammation in the body. There are all sorts of reasons why an ESR can be elevated. ANA is a little bit more specific for certain types of rheumatologic conditions, autoimmune conditions. Neither ESR nor ANA are going to correlate with or have any interaction with measurement of thyroglobulin. So I think those would probably be separate. In terms of what else you can do, I don't really know of any symptoms that elevated thyroglobulin would contribute to. I've never really thought about that, but I'm not aware of any information about or suggestion that thyroglobulin in the bloodstream produced symptoms itself.
Okay.
And I
thank
have
you.
patients with very high thyroglobulins who are totally asymptomatic.
Thank you. Are there any now in person? Okay, and while I walk over, there was a short question here, I think, but it could be a long answer. How long after thyroidectomy would you consider post-surgical hypoparathyroidism to be permanent?
So I've seen patients where the parathyroids have recovered 9 to 12 months after surgery. I think the conventional definition that the surgical groups use is a 1-year time frame to permanent hypopara.
Hello, my question is, so if you have a total thyroidectomy and you go to your 6 months ultrasound scan and there is evidence of residual, or if there's reoccurrent pops up, what comes next? I'm new, I just had my total thyroidectomy, and now my brain goes to like, what happens in the future is, if it's like in the neck or nearby area, do you do surgery again? Do you do some type of RAI? I'm just interested in what comes next.
Okay, so total thyroidectomy, is this the first ultrasound after surgery? Okay, so good. So it was not done too early. They allowed time for healing and the swelling to resolve and all of that. So this is the first ultrasound. And what I usually tell patients is, this is your new baseline. This is what we're going to choose to be following. Now, if you told me that your new baseline included a 3-centimeter lymph node that was positive for papillary cancer, I would say in all likelihood, the imaging and the surgery that you had initially missed that, and it's persisting and it probably should be taken out. If you told me you've got, 6 or 7 millimeter areas where the thyroid used to be, those are pretty nonspecific, can represent scar tissue, can represent persistent tumor, could represent small bits of normal thyroid remnant. So there's lots of things in the interpretation of the ultrasound that, need to be considered. But not to sound like a broken record, but if this is the more typical scenario where, like that latter one, where there are things under 1 centimeter in the area where the thyroid used to be and maybe some slightly enlarged lymph nodes, I'd see what happens to them over time before jumping in to do anything specific for them. And we can talk more detail offline.
Hi, I have a question about thyroglobulin post partial thyroidectomy.
Ah,
And So I had surgery about 4 months ago, and then my thyroglobulin has not decreased at all to my prior thyroglobulin pre-surgery level. And it did have like a spike even higher, and then it seems to kind of be going up and down. And I'm not sure if that's normal, or should it always be declining and end up settling at a level that is lower than your pre-surgery level?
Are you on thyroid hormone?
I just started, so
Okay. And did your TSH go up after surgery, above normal?
it was above 1, but it never went above 2 until very recently. So it was
Okay.
always like between 1 and 2.
So one of the things that I am aware of in the new ATA guidelines, what I've been told, is that they will no longer be recommending following thyroglobulin levels after a hemithyroidectomy or half the thyroid's been taken out. I'm waiting to see if that makes it into the final version. I do tend to follow thyroglobulins, though, in my patients who've had a hemithyroidectomy, not as much looking for the absolute level, but for trend over time. But again, you have to kind of look at it in total context. Immediately after surgery, thyroglobulin levels will often bump up in people, because when you've cut through the thyroid, you're going to have a sore area of thyroid that's going to be releasing thyroglobulin into circulation. So you can see that happen. So, I don't jump the gun and get a thyroglobulin very early. A good 6 months might be the reasonable time to get the first post-op thyroglobulin. But also thyroglobulin production is very much dependent upon TSH levels. And because thyroglobulin is produced as part of the machinery for the production of thyroid hormone. So if TSH is trying to tell the thyroid to make more hormone, it's going to tell it to make more thyroglobulin along the way. So you have to sort of do a little bit of mental correction. There's no real formula that says if the TSH does X, the thyroglobulin will do Y, but you try to look in somebody's sequential lab tests for some similar levels of TSH and say, what's happened to the thyroglobulin when the TSH has been constant? So, which is a long-winded way of saying that there's not really much of a definitive answer, but it's uncommon that I am able to diagnose persistent or recurrent cancer on the basis of a post-op thyroglobulin when only a hemithyroidectomy has been done. Now, again, if you told me your thyroglobulin was 1,000, then I might be more able to be suspicious. But if it's gone up a bit, and hasn't gone down below where it was pre-surgery, I'm not sure how to really interpret that.
So what would you consider like a rise in thyroglobulin? Like how much of a rise is important? Like if it goes from 11 to 17, for example, is that?
Not in that situation.
Okay. And would
And
you
that's still in
ever?
the lower portion of the range.
Okay. Is there ever a consideration for a total thyroidectomy solely to monitor thyroglobulin?
That was a logic that was used for many years, but it probably led to a lot of people having more surgery than they really needed.
Okay, we have about 5 minutes. Is there anyone that hasn't answered or asked a question? Did I see any hands over here? Okay, and then I'll try to, we just have about 5 more minutes.
Okay, back in 2002 is when I had a large goiter, 95% of my thyroid taken out. At that time, they did not find cancer. Fast forward to 2016, I was diagnosed with stage 4. Now, since then, I was on Lenvima, as well as now I'm on the Cabo because the Lenvima stopped. Now, when they were running the CAT scans and then the PET scans, they weren't really seeing as much until suddenly somebody said, where's the bone scan? And suddenly everything was popping. Now, my current oncologist is alternating between CAT scans and PET scans, when should I push to have a bone scan instead? Because last year it had started to spread and they only found it when they did the bone scan.
And what type of thyroid cancer was it?
I have both papillary and follicular.
And with the cancer that has spread, was there ever a biopsy to show what type it was?
One of my several doctors had run all the tests and she was saying it's papillary, but other doctors are saying it's follicular.
My guess would have been follicular, given the story that you describe, because sometimes people can have follicular tumors that are difficult to identify as malignant, and kind of this 10 years before they had, their thyroid taken out and it was all thought to be benign. And then lo and behold, it pops up 10 years later. And follicular tends to be in that story. But your doctors are doing what might be the most common approach. Bone scans traditionally have been pretty useless in following most people with thyroid cancer. We used to do them in following patients who had follicular cancer, but it turned out that, again, in most people, PET scans was a better way of detecting bone metastases than bone scans. However, every patient's disease is a little different than others. And if your tumors were better found by bone scan, even though that's not what I would have expected, that's what I would be using. That would be one of the techniques I would be using for regular follow-up. Maybe not every 2 months, but every 4 to 6 months, perhaps. There is a type of PET scan that's not based on measuring glucose or sugar, but is specific for bone metastases. It's a sodium fluoride PET. And sometimes that can be an even better test than a bone scan in some patients with bone metastases. So that's something to have a discussion with your oncologist. But I would be doing some sort of bone-specific imaging like that in somebody where it did not show up with other techniques. So I think you have to individualize based on that one specific patient, and not necessarily what the guidelines would automatically tell you to do. Sometimes it's a little bit of a struggle with the insurance company to get the authorization for those non-standard tests, but the argument being, it didn't show up when we did X, Y, or Z and only showed up with the bone scan. Ergo, the bone scan makes sense.
Thank you. And Dr. Sherman, before we end, I'd like to take one more online virtual attendee. Is there a credible website that shows how many surgeries a surgeon does a year or related info, or do we just simply trust a doctor's word?
That's a great question, and I have no idea, specific to thyroid surgery. There are some websites for, things like cardiac bypass surgery that give you information by individual hospital and individual surgeon. I don't think that's available for something as less common as thyroid surgery, but I don't know. And that's something that actually I need to find out about. Meaning that, I think probably the best option you have is, in fact, asking the surgeon directly. You also have a great peer group here in ThyCa and on the, in the conversations and chats on ThyCa's website. So I think sometimes you can find out a whole lot of information about your surgeon from other people's earlier experiences.
Okay, so thank you so much for your presentation. And this concludes this session. Thank you, Dr. Sherman.
Thank you very much.